Okay. With that, I will go into my topic. And so I'm from Northeastern Illinois University, and you might not have heard about, but it's the smallest university, sufficient enough. It's like having 15,000 students, and it's in Chicago. And so this work on Leishmaniasis, it's a vector-borne disease, and it is also a neglected disease, and I will explain why I am stressing on the word neglected. So this work has been going on for quite some time with my collaborators at various places, and I want to acknowledge these people first before I go into what I will be talking about. So there are many of them. Especially this Rajendra Memorial Research Institute of Medical Sciences, which is Patna. My focus is in India, Bihar. That's where I'm focusing my research on, and actually this is the first of its kind, especially because of political reason, because of the social reason. There's many different reasons that restricts our attention to many other factors which we do it for other diseases, for example, easily. So Leishmaniasis. So Leishmaniasis is actually a family of disease, family of vector-borne disease, and the family is kind of subdivided based on your clinical manifestation or the reservoir host in that region. So there's, as it is a vector-borne disease, so therefore vector is involved, and the vector is a sandfly here. Parasite is Leishmania, and the host are mammal host. Some places it is humans only, and some places it's a mix of humans and animals. Asia, which deals with this disease. And they are also part of the political system because they recommend the government to design a policy in that region. We also collected socioeconomic data, which consists of census coming from Census of India and also Bihar state surveys. So we give a term to that, and we are calling it as a partially observed data, and because it comes from passive case detection. What that means is that the patient has to go to the hospital in order to be reported, yes, this is a first case or second case. So they don't go for actively looking for where is the cases. So, and only from public health clinics and government institutions, that's what is reported. So this is one thing which I'm trying to focus on. Second thing is a large variation is observed in epidemiological quantities. Like infectious period, incubation period, all these things have a huge variation in that. And one primary reason for that is probably that misuse of drug or misuse of treatment, or could be any other reasons also. Malnutrition, for example. That is the variation. For example, infectious period 20 days to 1 year has been observed. So how do I take this account into a model and answer these questions in an effective way? So what we will, first I will, so this stage progression model, which many of you might have heard about, is capture this variation in a better way than a regular exponential waiting time based model, basically. So just to give you a recap of a simple stage progression model, it looks like that. Basically what you are saying is that anything, in this example I'm taking infectious compartment, goes through the stages, and there are n of them, stages. If you see carefully, all the rates are same coming out of each one of the II scars. So what is a good point here is, in this model, is that you have a sum of, the infectious period is actually total from when you enter I1 and you exit IN class. So it's a sum of n independent exponential. If you think in a stochastic process way, then it is basically a sum of n independent exponential variables, and the sum will lead to a gamma distributed random variable, actually. And this is not a stochastic, I'm talking in terms of it. So expected value turns out to be 1 over gamma, and the standard deviation comes from 1 over gamma square root n. So why I'm saying this? Because now we will use two sets of data. Not only, so in general deterministic model, we estimate parameter by a single value. Here we are using two sets of data. Not only that expected value, but also standard deviation. Why we are using? Because we are not sure of n here. We are not sure of how many n's we should have. This, if you know the standard deviation of an infectious period in the field, then you can write it equal to that, and you can compute how many n's you will need. Is that making sense? So this is very important there. We are using more set of data because the variation is quite large. So this is the model of the Kala-Azar that we have built and analyzed. In this, again, it has many stage progression model in the incubation period. Wherever the variation we could find, we have done this stage progression. For example, in exposed class, for example, in infectious period, treatment, these are two treatment classes, and I'll explain to you in a few minutes, and also incubation in the vector. So treatment, for example, is divided into two parts. One is G and one is T, and G is a public health clinics treatment, patients going through the treatment in the public health clinics, where T is considered as patients going in a private health clinics. So it's a very simple SIR type model, and it's right on the discussion that we had yesterday. That simple SIR model can still incorporate some of the things, especially in vector-borne disease, and Ava would agree with that point. So this is what is being reported, and this is what is not known, basically. And my goal here is if I can find this little p or 1 minus p using this reported incidence and can quantify this p actually, basically that's what 1 minus p will give us underreporting proportion basically. So we use the stage progression. Okay, so let's go. So what happens is when we use this real data, we get number of stages. For each of the variation that we incorporated, we got number of stages for that. And so it was a very high dimensional system, and we did do some mathematical analysis by simplifying it a little bit. And I should have kept my paper there, but feel free to discuss with me after this lecture. And so the result says the underreporting levels are like this. So these are the districts, most affected district. There were 21 of them, and these are arranged. So there are two bars you are seeing, blue and red. Blue are from 2003 data, and red is 2005 data. And it is arranged, the district is arranged based, first of all, this vertical axis is the percentage of underreporting. How much underreporting has happened in each district in 2003 and 2005. The districts are arranged in a way that the difference from 2003 and 2005 is reducing if you go from left to right. So if you see there's a high decrease here, where there is very low decrease here, and on this side it is kind of increased. After this line it is an increase, and after this this is actually the total state. It's a complete state, and these are 21 districts there in that state. This state consists of 38 district total. So what it is showing is that that it is actually giving you a spatial quantification of underreporting levels in that state. So what we have found is that there is 88% underreporting. That's quite a high underreporting in that region. 88% of any disease, I would have not imagined. So before doing this study, now I know. And then in 2005 it was 73%. And it has reduced quite drastically from 88 to 73, and we didn't know quite a lot why it happened. But then I went on to do the literature review, and I found something which I will tell you in a few minutes. So what we have seen here is there is a decline from 88% in 2003 and to 73% in 2005 in underreporting levels. Also, there are many districts that were above 90% levels of underreporting. That's also quite high. I mean, it sounds like most of them were not reported, basically. And so what we did was we plotted it on the spatial part and wanted to see if we use the reported data, because the policies are made on the reported data, whether how much portion is covered. And it seems like if you see the shaded one, the stripes ones is a reported and adjusted is the shaded one, they are not matching at all in terms of a risk, which are the risk districts, high risk districts, and which are not. Actually they completely misidentified many of them actually. So because they were using reported data. Okay, so what we said from this study was there is a 17% decline from 2003 to 2005 in underreporting levels. In fact, reported data was saying that there is an increase of cases, 1.5 times cases in 2005 as compared to 2003. Reported data was saying there is an increase in 2005 of cases, whereas we are saying no, there is a decrease of 28%, and you couldn't able to quantify something which was very important. So the reason, so I went on to the literature to see the reason why is this discrepancy, and I found that there is a Kala-Azar task force that was established right at the end of 2003 by WHO. And they did many of the policies in that region during that time, starting to end of the 2003, and therefore these benefits were observed. We could see it in the 2005 basically. So actually they are using this this results now in implementing 2011-2020 policies for the state government. Okay, so then second thing what we get, once we quantify this underreporting, this actual how many people are infected there, now the next part was to identify any of the risk factors that could, yes?
Sorry to interrupt you, but was the task force differentially applied to those different regions to get the reporting rates, underreported rates to go down in some but not others? I'm trying to understand why overall it went down, but in some it went down a lot more.
Yeah, so
much more effective in some regions?
Yeah, so I don't know if it was, so again, this, so WHO says, okay, you have a policy, I will give you money, you implement that thing effectively, and they have the person seeing it. Now, state government has to decide where to put those money and where to put the structure. They really don't know. In a lot of places they don't know. So they put these control measures specifically in high density areas, and they may not be the case which is relevant for the disease itself. So that could be the reason, but I'm not sure of that. I don't have a direct answer to your question actually.
Well, what I'm getting at is, was the task force more effective in some reasons in the drop in cases, underreported cases, in specifically in those regions that it was effective in? Or is it just, was this not in some regions you still got the same problem?
See, that is difficult to answer because, I mean, we have to see where these policies are implemented. I mean, I'm talking in a state level now, actually. That's a good point. And actually, we can work on a project like this one, so specifically focus on task force efforts. But sorry, I don't have the direct answer to that. So, okay, so we'll go on the next, I think I have a few minutes. Yeah. Okay, so the second is the socioeconomic risk factors, how they are affected by the adjusted incidence. And so we took many of these adjusted factors, I mean socioeconomic factors like education level, worker types, housing. Worker types is like where do they work? Does it matter where do they work? Yes, it matters. Whether they are farmers because they are in field, this is a vector-borne disease. So it matters where they work. If they work in a factory of 200 people next to each other, then they are more likely to spread if there is a sandfly present in that. So it is very much important where they work, where they live, what type of houses they live on, what type of education levels they have, because the decisions they take on that, and what type of villages and public health transportation are present in the villages. And all these things are very, very crucial at the field level. And of course the climatic condition which affect the density of the vector. So what we did was we generated this spatial models, statistical models to identify these risk factors. So our dependent variable in that case was incidence, and the predictive variables were socioeconomics and climatic factors. And we used best subset algorithms and the regression models to identify some of these factors, and we found some of them consistently found in three years, 2003, 2004, 2005. These are adjusted incidence, adjusted of underreporting. So I'm now computed the new right incidence and then trying to see the effect of these factors. And then the age groups of the people in that population density is also very important. Also is education level and medical facilities available in it. So the conclusion for that is that proportion of factory workers are found to be very important for adjusted incidence. How many people are there working in a factory basically. And also what we find is that medical facilities and primary educations are two crucial factors in the predicting that. So literacy rate is found to be correlated with underreporting proportions, but here we are talking about adjusted incidence, and here we are talking about underreporting proportion. So literacy rate and population density were the two highly correlated with underreporting proportion. These are very important for identifying this. So I'll take No? Okay, so let me show you what this model is. Actually, second, then we discussed about cost effectiveness of control measure, but I will not go over all these things. So I will show you the model that we generated. We had an optimization model, and we analyzed this model. So the idea was that there was insecticide spraying cost. So we optimizing over the spraying part, and then death rates are the constraints in the houses and the sheds, death rates of the sandflies. And anyway, so let me give you the methodology what we did here. So we had a dynamic model, differential equation based model. We used the reported incidence and the epidemiological point estimate data to quantify the case reporting here, and then case reporting, underreporting is used to compute the adjusted incidence. Adjusted incidence was used in a spatial regression models and a socioeconomic data, and we found significant socioeconomic variables, where to put money, what are the factors which are important. And then we, on the other hand, we also generated an optimization model here, which is based on how much we should allocate in insecticide, because vector control is a primary method for this thing. And based on that, we have found some kind of implications from that. And these are the general implications from it. And for example, educations are very important for them to, I mean, these are general implementation, but when you have 30 different things, then it is very hard to actually identify which one can you pinpoint, and whether it is a toss of coin or whether it is you can give a reason for why you are identifying. So that's the reason this step-by-step procedure was very helpful to identify a few things here: population density and education. Also I mean, we want to control this disease by 2015, WHO says that, but we cannot, because there are many things are lacking there, and in fact by 2050, if we could control it, that would be also good. Active case surveillance is very important. We have to have a dialogue, or we have to have some quantification of how many private doctors are there and how they are reporting to the State Health Society. So with that, thank you.